I think it's very fitting that our first speaker is Dr. James Fagin, who is the head of the Division of Specialty Medicine and a member of the Human Oncology and Pathogenesis Program at Memorial Sloan Kettering Cancer Center. He's also professor of medicine at Cornell University. Jim Fagin entered the field of science and medicine at the dawn of molecular revolution, if we can call it that way. And he over the decades, he has been instrumental and pioneered sort of molecular approaches to thyroid cancer. From the early days where his group was involved in describing the first oncogenic event and that occurred in thyroid cancer, to more current days when he's focusing on understanding of new mechanisms of cancer and how to bring them to therapy. Among multiple accomplishments and achievements of Jim and his group are identifying the mechanism of restoring radioactive iodine avidity by tumors, first in mouse model and then in disease, defining novel mechanism of adaptive resistance of BRAF mutant thyroid cancer to MAPK pathway inhibitors, and many other areas. So today he's going to give actually 2 talks at the symposium, and his first talk that he's going to give now is called Genomic Predictors of Sensitivity and Resistance to Radioiodine Therapy. Welcome, Jim.
Thank you very much, Yuri, and good morning to everybody, wherever you are. What I would like to do over the time of my talk is to discuss the underpinnings of what determines differentiation in thyroid cancer and how that impacts radioiodine therapy. And I'm going to begin by sharing the current or the 2015 thyroid cancer guidelines for indications of adjuvant radioactive iodine. And this is just a summary of some key aspects of the approach that the Guidelines Committee took to this problem in the absence of any prospective randomized clinical trials could support this based on the highest quality data. So, as you know, the American Thyroid Association considers thyroid cancers into 3 risk categories: low risk, which are usually small, non-invasive papillary thyroid cancers, lacking any aggressive histology and with few or no lymph nodes involved. The intermediate risk category, which is one they recommend to consider for radioiodine therapy, is associated with tumors with microscopic parathyroidal invasion or vascular invasion, more significant nodal disease, either through their size or their number, in this case greater than 5 lymph nodes involved, and micropapillary thyroid cancers with extrathyroidal extension, for instance, and if they are BRAF mutant. And then for the highest risk category, and here we're talking, of course, about risk of recurrence, the presence of gross extrathyroidal extension, incomplete resected tumors, large and bulky nodal disease, and presence of distant metastases, or the presence of a high postoperative thyroglobulin as a predictor of persistent disease, or follicular thyroid cancers with extensive vascular invasion. So what I'd like to do is to now switch to discussing a little bit about the genetics of papillary thyroid cancer with data that many of you have heard in the past, and then try and connect this information to these specific recommendations. So as many of you have heard before, in 2014, this seminal paper was published in Cell looking at the genomic and transcriptomic features of approximately 500 papillary thyroid cancers. And what was found at this time was that approximately 60% of these tumors harbored BRAF V600E mutations. Another set, approximately 12 to 15%, had RAS mutations, and another similar proportion had various fusion oncogenes, primarily of receptor tyrosine kinases such as RET and TRAC ALK, and others. All of these were non-overlapping, and the pathway they all share in common is the activation of the MAP kinase pathway. So based on this information, it was possible then to try and correlate the genotype of these tumors with their gene expression profiles, which is what is shown here. And shown in this heat map, what you're looking at is specifically the genes that are involved in iodine metabolism, and it's another way of talking about the thyroid differentiation state of these tumors. And in green, what you're looking at is genes that are downregulated or their expression is low, and in red, the expression being high. And bracketed by this arrow, these genes involved in iodine metabolism. And as you can see, in the BRAF V600E tumors, the expression of these genes, which include, among others, the sodium iodide syn-porter, thyroglobulin, and others, was downregulated. Whereas in those tumors that harbored RAS or receptor tyrosine kinase fusions, they were relatively preserved. Now, there was an exception to this in a subset of tumors with BRAF mutations that do, for reasons that are unexplained, retain some degree of differentiated function, as you see here. The explanation for this is still, not fully resolved, but it's thought that perhaps expression of certain microRNAs may be involved in this process. So the question then to ask, and this is important because if you think, well, this gene expression profile, to what extent is it telling us about the ability of these cells to trap iodine? And we would expect those tumors that have very low expression of these genes to not do it very efficiently. And since there is a subgroup that actually does retain differentiated state, and we score these tumors as being, with a score called thyroid differentiation score. And what you're seeing in this table on the right here are those tumors that had a low thyroid differentiation score, but were BRAF mutant. On the left side, and on the right side, those that had a preserved differentiation score. And interestingly, and this is work from Laura Bucay, what she found mining the TCGA data is that these tumors that retained differentiation despite having BRAF mutations tended to be smaller, have fewer nodal involvement, and presented with less frequent distant metastases. So by and large, most of these patients, based on ATA criteria, would probably not have been selected for radioactive iodine treatment anyway. So based on the expression of these genes and the activity of the MAP kinase pathway, the TCGA group separated the tumors in two groups. Ones would behave more like BRAF, V600E, these are BRAF-like tumors, and others that behave more like RAS tumors or RAS-like. And as you can see below, their ERK signature, which is a marker of MAP kinase output, is high in the BRAF tumors and low in the RAS-like tumors, and their differentiation score goes in the opposite direction. And here are the individual mutations, and you can see that those tumors with receptor tyrosine kinase mutations, by and large, lie somewhere in between this BRAF-RAS-like score system. Looked at in other ways, this is, again, same data, but now comparing this thyroid differentiation score to this BRAF-RAS score. And you can see most of the BRAF tumors shown in blue have a low thyroid differentiation score, whereas the RAS tumors have a high one, and these are the receptor tyrosine kinase mutant tumors. And if you just look at the BRAF V600E mutants, these would be the ones that retain some degree of thyroid differentiation. But note that the score is still negative as compared to the BRAF, the RAS tumors, where the score is approximately 1. So even though they are more differentiated than the mean, they still have attenuated differentiation. So how do we explain this biochemically? Well, again, we take these three classes of oncogenes, BRAF V600E being one, RET rearrangements, and other receptor tyrosine kinase another, and the third being the RAS mutant tumors. They have classical histological characteristics that I'm not going to go through right now, but they also signal differently. So let's begin by talking about like a canonical signaling pathway, which will be the activation of a receptor tyrosine kinase, normally by a ligand. But in the case of these fusion oncogenes, these become constitutively active through the recombination event. And the way they signal is that they activate RAS, which in turn recruits RAF dimers to activate the MAP kinase pathway. And the downstream target of this is ERK. Once this is activated and phosphorylated, it actually provides a negative feedback upstream, to try and essentially shut the pathway down. So this is the normal homeostatic control of MAP kinase signaling. In the context of the BRAF V600E mutation, BRAF actually signals as a monomer. It does not require dimerization. And therefore, it activates ERK robustly and is unresponsive to negative feedback. And that is why the output of the MAP kinase pathway is high. And on the other end of the spectrum, the RAS mutant tumors are the ones that have an intact feedback and the lesser activation of MAP kinase. And you can see here that the suppression of the differentiation state is reciprocal to the activity of the MAP kinase pathway, which is illustrated here. So now let's return to the PTA risk classification. And what I highlighted in red are those characteristics of tumors that would be enriched for BRAF V600E mutations. And as you can see, both in the intermediate risk and in the high risk setting, many of these characteristics would occur for tumors with BRAF mutations that would be relatively unlikely to respond to radioactive iodine. So in the categories where adjuvant radioactive iodine is recommended, there's a significant concern that we are recommending treatment for disease that is likely to be unresponsive. So summarizing this aspect of my talk, the consensus expert recommendations for adjuvant radioactive iodine treatment are based on retrospective studies, despite their methodological weaknesses and biases. Most invasive tumors or cancers with significant local regional nodal disease are treated with radioactive iodine after surgery, which is problematic because they're enriched for BRAF mutations and are likely to be mostly unresponsive to radioactive iodine. So regardless, patients with persistent or recurrent nodal disease or distant metastatic disease are treated irrespective of tumor genotype. And the final point here is that measuring efficacy of adjuvant radioactive iodine is challenging. At this point, we never really know when we're treating these patients whether we are really benefiting them or not. So another way of looking at this is, well, let's look at a circumstance where we can determine whether radioactive iodine is effective or not, which is in metastatic thyroid cancer, where there is identifiable bulky metastatic disease. So the study that we did was also done by Laura Bucay. And what she did is to screen the Memorial Sloan Kettering database for patients who had been treated with radioactive iodine in the years between 1985 and 2018. And the numbers are shown here. Altogether, what we did is we ruled out those patients with undetectable, we ruled in the patients with undetectable thyroglobulin antibodies to avoid the confounder. And then specifically look for patients who at any point had a thyroglobulin level greater than 200 nanograms per milliliter. And Laura found 221 of those. And then what we looked at is the thyroglobulin nadir post-radioactive iodine treatment. And 34 patients actually had a nadir less than 20 nanograms per milliliter. And of these, those that actually had a structural disease response by RECIST version 1.1 were only 11. And I'm illustrating these cases, one of these cases here. This is a patient with metastasis to the lung, as indicated by the arrows here. And after the patient was treated with several doses of radioactive iodine, you can see that the disease essentially is no longer apparent. So what we did is we performed whole exome sequencing on these patients with what we called exceptional structural responses to conventional radioactive iodine. And you can see that these were enriched for RAS mutations or a BRAF mutation that is called a class 2 BRAF mutation. This is not the V600E mutation. And this particular type of BRAF mutation signals very similar to RAS. It requires RAF dimerization and therefore is responsive to negative feedback. And the other three were receptor tyrosine kinase fusions. There's one more that is still being analyzed. We were unable to obtain tissue from some of the others. And we've done a case control study that is still ongoing, where for each of these cases, we did a very carefully matched control set of 2 patients per experimental one that had not responded to radioactive iodine. And those, by contrast, were enriched for BRAF V600E mutations and had a number of associated mutations, in part of chromatin modifier genes that essentially disabled their ability to respond to radioactive iodine. So, summarizing then, what we have found in terms of studying patients who had structural responses to radioactive iodine is that they are enriched for lesions that are either receptor tyrosine kinase or RAS-like because they signal through RAF dimers and therefore can respond to the negative feedback and have an attenuated activation of MAP kinase, allowing a relative preservation of their differentiation state. This is summarized here. Just to conclude this aspect of the talk, metastatic thyroid cancer then that show major structural response to radioactive iodine are enriched for mutations that constitutively activate RAF dimers, such as RAS mutations, class 2 BRAF mutations, or RTK fusions. So, as Yuri mentioned, we have been interested for a number of years in seeing in which way interrupting the MAP kinase pathway with various small molecules that have selectivity against various effectors in the pathway can actually reverse these effects and restore differentiation. And so the first study that is well known to this audience, because it's been published many years ago, relates to test this concept. And just to give you some background, we were interested in this beginning in cell lines and then in mouse models and in a study that is characterized by this slide. And so these were mice that we engineered to express BRAF V600E in the thyroid, but under very controlled settings, only when we treated these animals with doxycycline, which is just a tool compound to be able to activate a genetic lead-driven pathway to switch on BRAF expression. And what you're looking at below is the expression of thyroid differentiation genes, and circled here is the sodium iodide symporter. And this baseline, 1 week after switching BRAF expression, there's essentially almost complete silencing of the thyroid differentiation genes. And if you switch off the expression of BRAF, you can restore this, which is shown here. And what we did is we then went ahead and did radioactive iodine uptake studies with iodine-124, both by switching the gene on and off, and then by using a MEK inhibitor, this tool compound, or a RAF kinase inhibitor. And a treatment for 1 week with either of these did restore radioactive iodine in a very significant extent in these animals. So based on this, my longstanding colleague, Alan Ho, who's essentially the leader of all the clinical trials aspect of the work that we do, and here are listed some of the other key participants, but I should say that this is work of an entire disease management team, across various services, but these clearly are the key people who have contributed most to this work. So this is essentially returning to this proof of principle. In this case, the drug that we used was selumetinib, a first-generation MEK inhibitor. And the design of the study really approximated what we had done in mice. We did iodine uptakes with iodine-124 at baseline, treated the mice with selumetinib for 4 weeks, then repeated the scan. And in those patients whose scan actually determined that we could predict that we could deliver a lesional absorbed dose of 2,000 centigrade, these continued selumetinib for an additional week and were treated with radioactive iodine. Then the drug was stopped. And results of the study have been published, as I mentioned. These are just 2 examples. You can baseline this patient has a few metastatic sites with modest radioiodine uptake, which is markedly enhanced by treatment with the drug. This is yet another case as shown here. And altogether, in this pilot study, 12 of the 20 patients had increased iodine incorporation, 8 of which went on to receive therapeutic radioactive iodine. And of these, what we found was a marked enrichment for RAS mutant tumors in the response category. So those tumors that harbored RAS mutations actually responded with a very high frequency, whereas those with BRAF not, as illustrated here, 4 of the 9 patients with BRAF mutations did have an increased iodine uptake by treatment with the drug, but they didn't meet that 2000 centigrade threshold with the exception of a single patient. This is the overall response rate of these 8 treated patients, and this is the best response at 6 months. You can see that there was marked reduction in tumor size and 5 meeting criteria for a partial response. So one of the issues with this drug is essentially, as illustrated here in the right panel, is because MAPK inhibition also affects normal cells, and inhibits the MAPK kinase pathway in essentially all cell types, the therapeutic window for this drug is quite narrow. So what is required for effective tumoral target inhibition is very close to the maximum tolerated dose. Whereas BRAF inhibitors are different because Vemurafenib, which was the lead compound first used, essentially inhibits the RAF monomer, but actually does not inhibit RAF dimers. So the therapeutic window is much greater. And so we were interested in seeing what type of results we would see with Vemurafenib. And this is a study that was done by Lara Dunn, who's now a faculty member in our group. And you see here, these are the results of selumetinib with BRAF tumors I showed you a minute ago, whereas with Vemurafenib, though these are very small numbers, again, remember, these are all pilot proof of concept studies, the number of patients who actually responded to radioactive iodine was greater, but 4 of them actually met the criteria for receiving radioactive iodine, and so a couple of these are illustrated here. So the interesting aspect of the study is that what we intended to do was also to do biopsies prior to and while the patient was on Vemurafenib. And the intent here was now to measure the same sort of set of transcriptional output markers that had been determined by the TCGA group. And one of these is the MAP kinase output score, which is shown here. And as you see in these 3 patients, patients 6, 7, and 9, the MAP kinase output at baseline is high and is inhibited by Vemurafenib. Another way of looking at this is looking at the BRAF RAS score, which is low to start with, meaning more BRAF-like, and high with on drug, meaning more RAS-like. So we're converting these tumors to behave more like RAS-like tumors. And what does this do to differentiation? Well, this is the thyroid differentiation score, which we enhanced computationally with additional markers. And as you can see here, these are markedly increased, but to varying extents. And interestingly, in this particular series of patients, the patient that had the greatest restoration of thyroid differentiation score was also the patient that had the most robust reactivation of RAI uptake as measured here. And you're looking at the SUVs and these I-124 scans, with the second patient being intermediate and the last patient showing the more attenuated response. Now, we mentioned selumetinib as the lead compound that we had first used. And selumetinib, although it's a good MEK inhibitor and is actually finally approved at least for one indication, not this one, it actually behaves in a particular way that when it binds to MEK, it actually does so by retaining RAF kinases in the complex. So that and this bound RAF tends to reactivate MEK and ERK signaling, and therefore you tend to get a rebound of ERK activation in patients treated with selumetinib. However, Trametinib, which is a different allosteric MEK inhibitor, blocks MEK but dissociates it from its upstream RAF kinase activity, partners, and therefore gives a more sustained inhibition of the pathway. So, based on this, Alan conducted this clinical trial. 2 cohorts, one which had RAS mutations, and altogether there were 25 patients, and they had the same design as we described before for selumetinib, with the exception that those patients who did not have a iodine uptake response were allowed to continue on Trametinib just to look at to allow them to benefit from the potential growth inhibitory effects of this compound. And these are the results, and you can see very strong improvements. 22 of the 25, that's 88%, had restored iodine incorporation, and 15 of these were eligible for radioactive iodine. That's 60% of the total. And of these, 8 had partial responses. That's 57% of those who received radioactive iodine. 12 had considered to be clinical benefit because they had either stable disease or a partial response, and only 2 had progressive disease. So clearly a far better result than we had with selumetinib overall. And the second group, Cohort B, included patients with BRAF fusions or class 2 BRAF mutations, of which we had, fairly decent activity, or with RET fusions. This is a very small group, so we don't have any firm conclusions on this. So if you look at our cumulative experience so far, and this is as of last year, we have treated almost 70 radioactive iodine refractory patients on redifferentiation trials. Of these, just about half of them received iodine 131 because they met the criteria that allowed us to do this. And among these, 18 had partial responses and 12 stable disease. And because these were all just pilot studies, we only gave them a single administration of radioactive iodine. But ordinarily, patients who are treated with radioactive iodine and respond to the treatment, we tend to give repeated therapies, sometimes every 6 months. In this case, they only received a single therapy and a single exposure to drug. So the long-term effects of this have not been fully outlined yet. If we just look overall, just in these pilot experiments, at the time to subsequent therapy or death as a marker of response, those patients that received radioactive iodine had significantly better outcomes than those that did not redifferentiate. Now, whether this is due to the effect of the radioactive iodine treatment we gave them, or it's that these have different biologies intrinsically that makes them behave differently, and that radioactive iodine is not responsible for any benefit, is something we cannot discriminate on right now. I have to close by talking about events that could be associated with preventing responses to radioactive iodine, either in the conventional setting or in the redifferentiation setting. And we hit on this particular family of genes, components of the SWI/SNF remodeling complex, because we found them to be relatively common in thyroid cancer. This is the 13 to 14 multi-subunit complex, which can arrange into different complexes with different activities. But what was interesting is that when we looked at the TCGA data, these mutations tended to be subclonal, so meaning they were not present in every single cell. Whereas in advanced thyroid cancers, they were actually clonal, meaning that they had undergone microevolution and were selected for as the tumor became more and more aggressive. So what is this SWI/SNF complex? So as you know, the DNA is normally packaged into these nucleosomes, and they essentially the DNA is winding around this core sort of set of proteins called histones. When they are packaged in this way, the DNA is not accessible for transcription. And so there are this SWI/SNF chromatin remodeling complex, its job is to essentially unwind these nucleosomes and allow this DNA to become accessible for transcription to take place, as is illustrated here. So when these genes are mutated, though, this process is disrupted. And I won't go through this complex slide in detail, other than to say that we actually introduced mutations of 3 key members of this chromatin remodeling complex, and coupled this to activation of BRAF in thyroid cells. So if we just activate BRAF, we get papillary thyroid cancers, as you might expect. But if you actually do this in combination with any of these SWI/SNF chromatin remodeling complex genes, you actually get advanced polydifferentiated or even anaplastic thyroid cancers. And if you look at the Kaplan survival curve, these mice actually do worse and die sooner. So the main thing that we were interested here is, does this mean that the chromatin is more compact when you lose these genes? Then we were expecting this to be the case. And that's illustrated here by this sequencing technology called ATAC-seq, which is essentially only looking at the areas that are accessible, that are not compacted. And you can see that in the wild-type thyroid, the intensity and width of the signal are the areas that are accessible to transcription factors. Whereas in all of these three mutant contexts, this is actually markedly diminished. And if we now put a lens just on the genes involved in thyroid differentiation, in the wild-type context, these genes are accessible. So in red, you're seeing that chromatin is open. But in the three mutant context, they are closed. So essentially, these genes critical for differentiation are not available to be transcribed. And in these IGV plots, this is what you're seeing. This is PAX8. These are the two lineage transcription factors. And you can see that there are multiple peaks that show openness in the wild-type setting, but they are closed in the mutant setting. And this is the actual gene for the sodium iodide symporter. You can see very open in the wild-type setting, but closed in the mutant context, including in a well-documented enhancer of this gene. So we then actually repeated the experiments that we normally do to look and see if we can redifferentiate these. So we treated these mice for 8 days with either vehicle or a very potent MEK inhibitor. And I'd like to draw your attention to the slide here on the right. And what you're looking at here is the expression of thyroid differentiation markers. And let's just look at the sodium iodide symporter because all the others are very similar. And what you're looking at here is that wild-type context, meaning without treating them with a MEK inhibitor, as we described previously, the expression of the symporter is markedly decreased compared to wild-type, which we call 100%. If you have a BRAF mutation but nothing else, and you treat with the MEK inhibitor, you restore the sodium iodide symporter. And if you look in blue, you're restoring all the other genes too. But if you have these SNF chromatin remodeling complex genes mutated, you cannot restore their expression. So then we went back and actually did experiment with radioactive iodine, and we did an I-124 uptake in these mice. And without belaboring this too much, these are autoradiograms of the thyroid in the mutant context. You can see in the vehicle context, very little iodine is being incorporated. If you treat the MEK inhibitor, you dramatically increase the uptake in the BRAF mutant mice, but much less so in those that contain the SNF mutations. And that's not because we're not inhibiting the pathway properly, because you look at phospho-ERK, that's nicely inhibited across the board. But if you look at iodine-24 uptake, or the expression of the sodium iodide symporter, the presence of SNF mutations makes them unresponsive to the redifferentiation effects of MEK inhibition. And finally, if you now look at clinical trials, and we had this wealth of patients that we could look back on, we had done a study, which I'll explain later this afternoon in a different context, combining RAF kinase inhibition with inhibition of HER3 to redifferentiate these patients. And in this case, we had one patient shown here, and we had done biopsies at baseline, and then while the patients were on drug. And this, you can see here, is the iodine uptake after treatment with the drug. And shown here, this is patient 1. You can see that the thyroid differentiation score markedly improved Vemurafenib, excuse me, and even more so with a combination. And the MAP kinase pathway, as illustrated here, was inhibited, as shown here. This second patient had an ARID2 mutation as well, did not redifferentiate, and was unable to actually get any restoration of thyroid differentiation. The second trial is this Trametinib trial that I described to you earlier, and this is one patient with a RAS mutation who had also an IFAX mutation that redifferentiated beautifully. But these three others with that ARID1A or SMARCB1 mutations, SNF mutations again, these failed to redifferentiate. So illustrating then that genetics can also tell you not only whether a tumor is likely to respond to conventional radioactive iodine, but also whether they are amenable to redifferentiation by blocking the kinase pathway. So I'll stop at this point and thank you all for your attention. I try to acknowledge the many collaborators to all this work as I went along. Because I discussed so many clinical trials, we want to, specifically the contributions of our head and neck oncology group, which is illustrated here, in this case led by Alan Ho, my colleagues in the endocrinology service, Mike Tuttle, Mona Salra, Stephanie Fisher, Bukai, and our colleagues in nuclear medicine service as well as our biology collaborators and former lab members and current lab members as well. Thank you very much.